When a neurological crisis comes through the ED door, we're in a race against time. We all know that. When that patient is young, say in their 20s or 30s, our clinical alarm system, it just doesn't go off as quickly. Sometimes it doesn't go off at all. Today, we're focusing on one of the most urgent diagnostic challenges for frontline providers: stroke in young adults. We need to look at where our own biases lead us astray and what we can actually do about it right now.
And we have to start with just how big this problem is. Because I think for a lot of us, stroke in a young person feels like a zebra, a rare event. But that's just not right. It might actually surprise you that between 13 and 18% of all strokes in North America happen in people under 50.
13 to 18%, that's not a small number.
It's not a curiosity. It is a huge part of our practice.
Okay, so that single statistic should change the calculation for every clinician listening. What's the specific age range we're talking about here?
We're really focused on patients from their early 20s all the way through their late 40s. The challenge is just immense because the symptoms can look so benign, and the provider bias against the diagnosis is incredibly strong.
And the stakes are just so much higher.
Catastrophic. We're talking about preventing 50, maybe 60 years of disability.
So the goal then is to override these cognitive traps we fall into. What are the most common pitfalls that cause a provider to miss a stroke in a younger patient?
We've really narrowed it down to 3 critical traps. They're basically mental shortcuts we take when we're in a hurry, and in this case, they cause real harm. The first one, and it's probably the most powerful, is the too young bias.
Right.
It's that unconscious assumption that a 30-year-old with weakness or slurred speech must have something else.
Something like a conversion disorder or maybe intoxication, an atypical migraine.
Exactly. The diagnostic algorithm just stalls out before stroke even makes it onto the differential list.
I think we all recognize that impulse. You want the patient to be okay. So what's the clinical corrective, the thing we have to do every time?
It's simple, but it takes discipline. Stroke must stay on the differential for any patient between 20 and 49 who presents with sudden, negative neurological symptoms.
Sudden and negative, meaning a loss of function.
A loss of function. Sudden weakness, loss of sensation, a change in vision, trouble with speech. If the onset was sudden, you cannot dismiss it because of age.
Okay, that covers the clear loss of function. But what about those really ambiguous symptoms, the ones that could be a dozen different things?
That's our second trap, the mimic misdirection. This is when you have symptoms like isolated dizziness, vertigo, maybe a bad headache, and they get immediately blamed on something common.
Anxiety, an inner ear thing, maybe a history of migraines.
Right. You default to the benign diagnosis.
So how do you break free from that default setting?
You have to introduce an objective functional assessment. The most powerful tool here is the simple walk test.
Not just asking if they feel dizzy.
No. Ask them to walk a straight line, heel to toe. What you're looking for are subtle abnormalities that could point to a posterior circulation event, something in the brainstem or cerebellum. A slight deviation, maybe they can't quite keep their balance. That subtle gait issue could be the only objective sign that this is neurological. You don't test for it, you'll miss it.
And that's a test that's so often skipped if the patient looks generally well. Okay, let's go to the third trap. This is the one that happens after we start the workup. We get that initial scan back.
And we feel reassured. That's the false reassurance of early imaging. We lean so heavily on that initial non-contrast head CT scan. If it's normal, the thinking is no bleed, no big stroke, so no stroke.
Yeah.
This is a profoundly dangerous conclusion.
Because a normal non-contrast CT really only rules out a major hemorrhage and maybe a very large old infarct, right?
It's exactly right. Acute ischemia, a small fresh clot, is often completely invisible on a non-contrast CT for hours. So if the clinical story is screaming stroke, a normal scan does not rule it out. The corrective here is non-negotiable. If your suspicion is still high, you have to proceed immediately to a CT angiography. A CTA.
Of both the head and the neck.
Both the head and the neck. You have to ask why the neck, right? It's because we have to aggressively hunt for an arterial dissection. Dissection is a top cause of stroke in the young, and you will never, ever see it on that first non-contrast scan. If you stop there, you're missing the diagnosis in a huge number of these patients.
That's such a critical point. So avoiding the biases is step one. But step two is recognizing that the stroke itself just presents differently. How does it look different from that classic older patient? We have to look beyond FAST, facial droop, arm weakness, speech difficulty.
We absolutely have to. Because in younger patients, the presentations are so often non-classic. They're subtle, they're partial. And that just feeds right back into that mimic misdirection trap. For instance, one key atypical presentation is an isolated sensory deficit.
So just numbness or tingling?
Yeah, numbness, tingling, maybe a weird sensation in an arm or a leg, but with no motor weakness at all. The patient can still grip your hand just fine, so it gets written off as a pinched nerve or anxiety. But a small stroke in the thalamus can look exactly like that.
And what about changes in mental status? That's where I think misdiagnoses happen the fastest.
Absolutely. You can see sudden confusion, acute personality changes, neuropsychiatric symptoms that look just like a new onset of depression or psychosis. And because a younger person might already have a history of anxiety, for example, the team defaults to that diagnosis. The patient ends up on a behavioral health unit instead of the stroke unit.
The guiding factor has to be the onset. Was it acute?
Was the change sudden and profound? That's the key. And finally, that headache piece you mentioned earlier. An isolated severe headache. Most headaches are benign, of course. But a sudden thunderclap headache, one the patient says is the worst of their life or just indifferent. That can be the only symptom of a stroke.
Okay, so if we navigate the biases and we spot the atypical signs, the workup then has to find the cause, which is also different. What are the unique etiologies in young patients that demand that bigger workup?
The causes are just far more diverse than in older adults, where you're mostly dealing with atherosclerosis. As we touched on, a leading cause is arterial dissection. It's essentially a tear in the inner wall of an artery, usually in the neck or head.
It's a mechanical event, so sometimes there's minor trauma, a sudden neck movement, but it can also be spontaneous.
Exactly. The second leading cause is cardioembolism, a clot that travels from the heart to the brain. In younger patients, this is often from structural issues they've had their whole lives, like a patent foramen oval, APFO.
Right, that small opening between the heart's chambers that didn't close after birth.
Yes, and it allows a clot to bypass the lungs and go straight to the brain. We call it a paradoxical embolism.
And beyond those structural causes, what about the blood itself?
Then you have to investigate hypercoagulable states. These are, inherited or acquired disorders that just make the patient's blood more prone to clotting. So this huge diversity of causes means you can't just stop at a lipid panel and a blood pressure check. You have to launch an aggressive and expanded workup, vascular, cardiac, and hematologic.
Getting to that workup requires getting the acute treatment right first. And for that, you need systems in place that override individual bias. So what specific protocols can hospitals implement to speed up that diagnosis and intervention?
Systematic approaches are everything. It starts before the patient even gets to the hospital. Strategy 1, maximize pre-hospital screening tools. EMS has to use validated tools like FAST, and especially the expanded BE-FAST balance, eyes, face, arms, speech, time.
That pre-alert from EMS is invaluable. What about once they're at the door?
Strategy 2, organized stroke protocols. This means rapid triage and a direct-to-CT model. The goal is to bypass the usual ED processes and get the patient imaged immediately. The clock is absolute. We are aiming to start time-sensitive treatment within 60 minutes of arrival.
60 minutes.
Strategy 3 is making that EMS pre-notification mandatory. It's a simple protocol. EMS calls ahead with a stroke, regardless of the patient's age. This one thing is proven to shorten door-to-imaging and door-to-needle times.
And of course, the best protocols in the world don't work if people using them aren't up to speed.
Which is strategy 4, targeted professional education. Continuous training is essential, and it has to focus specifically on these atypical presentations in young adults, the isolated sensory stuff, the neuropsychiatric changes, because that's where the delays happen. And public campaigns help too, so patients themselves know to seek care immediately.
So it all comes down to recognizing that the young stroke patient is a different entity. The workup, the causes, the consequences of missing it, they're all different. Vigilance against our own biases is really paramount here.
It has to be baked into the system. Maintaining a high index of suspicion is the single most critical strategy. If we consistently apply these systematic protocols, we can make sure a young person's future isn't defined by a diagnosis that we missed on a busy shift. I'd really encourage you to go back and evaluate your own facility's ability to consistently meet that 60-minute arrival to treatment goal. For every single stroke alert, no matter how old the patient is,